Well, good evening, everyone. Welcome. Thank you for being here tonight with us. I'm David Dodick. I'm a professor of neurology at the Mayo Clinic here in Scottsdale, Arizona, and I'm fortunate to chair the board of directors of the American Brain Foundation. Tonight, we're going to be hearing research on Parkinson's disease, a disease that affects nearly 1 million people in the United States and is projected to climb to 1.2 million by 2030. As you know, the American Brain Foundation funds research across the entire spectrum of brain diseases because we know that these diseases are interconnected, and curing one means that we'll be able to cure many. To that end, not only do we fund research in Parkinson's disease annually through our Next Generation Research Grant Program, but we're also working closely with the Michael J. Fox Foundation to fund research in pursuit of finding a biomarker for Lewy body disease, which certainly shares many features with Parkinson's disease and Alzheimer's disease and Lewy body dementia. As of today, the American Brain Foundation has invested more than $33 million in research and granted scholarships and funding to more than 270 researchers. And almost 90% of those researchers have gone on to very successful research careers with NIH funding. The American Brain Foundation's most important partner, of course, and our founder is the American Academy of Neurology. It's the largest professional association of neurologists and neuroscientists in the world. And every research grant that we make is vetted by the Academy's top scientists. We're committed to sharing valuable resources and increasing public awareness of brain disease. And our virtual salon events like tonight are opportunities to connect you with the experts in various topics of interest around brain disease. So let's move into our topic of conversation for tonight, which is Parkinson's disease with Dr. Matt Stern. Dr. Stern is a friend and a colleague who taught and co-founded the Parkinson's Disease and Movement Disorder Center at the University of Pennsylvania, which he directed for many years. He's also the founding director of Parkinson's Disease Research, Education, and Clinical Center at the Philadelphia VA. He was a member of the National Parkinson's Foundation. He served the executive of the Michael J. Fox Foundation. He was president of the International Parkinson's Disease and Movement Disorder Society, having received what arguably I would think would be their highest honor, which is the President's Distinguished Service Award. And I've known, Matt is clearly a world beater in the area of Parkinson's disease and clearly a renowned expert and pioneer. But what I didn't know, and I just learned recently, is that the University of Pennsylvania recently established the Howard Hertig Matthew Stern Professorship in Neurology to commemorate Dr. Stern's contribution to Penn medicine. Many, many publications, many books, and I'm going to stop here because I could continue to go on. I don't want to read his CV, but clearly he's one of the most internationally renowned experts in the field of Parkinson's disease. So, Dr. Stern, welcome. Thank you for joining us this evening.
David, thank you for having me. It's good to see you. And again, thank you to the American Brain Foundation for all the incredible work they've done for so many years in supporting research into neurological diseases.
Thank you, Matt. So the way we normally do this, for those of you who have joined us before, is I introduce an expert like Dr. Stern. He gives a presentation, and then we open it up for your questions. We're going to do it a little bit differently here. And I'm going to ask Dr. Stern some questions, and then we'll open it up for your questions because he's such an outstanding teacher. We'll just let him riff on some questions that I'll ask him. So I know that some of you are neurologists, some of you are neuroscientists, but many of you are not. And so we'll start with just some fundamental basic questions. And so, Matt, I'll ask you for this audience here tonight. Tell us, what is Parkinson's disease and how do you and others make the diagnosis?
Well, I'm going to talk as if the audience is predominantly non-neuroscientists, and I think that would probably be more appropriate for this audience. But for most of you, you know that Parkinson's disease is a neurologic and neurodegenerative disease whose primary, most noticeable manifestations are a tremor, slowness of movement, muscle rigidity, that can affect folks at almost any age, even though predominantly it affects folks in their late 50s and 60s. But we see Parkinson's disease in patients in their 30s even. So it's very common. It affects about 1% of the population. There are a whole host of other symptoms. In fact, it's usually the other symptoms that cause more disability, like gait and balance problems, speech issues, bowel and bladder problems. So it's a very, very common disorder that can affect patients' well-being in any variety of ways. The good news is that we're very effective now at being able to treat many of the symptoms of Parkinson's disease, and patients can live very, very long, productive lives with the right kind of therapy. So it's the era of treating Parkinson's disease today is very, very different than when David and I first started in this business, when it was a little more challenging.
So, Matt, what gets you excited about the research that's being done in the field now, and what do patients have to look forward to in terms of new therapies coming down the pike? Because as you said, you know, we're much better today, but we've got a long way to go, right?
We do have a long way to go, but I want to put this in the context of medicine in general. You know, we've achieved so much in 21st and 22nd century medicine, largely through disease prevention and early detection. Think about cancer, for example. Think about getting mammograms and colonoscopies. We do that primarily for early detection. And when we pick up something, we can treat it early, and treating earlier is better. That whole era is beginning to happen in neurodegenerative diseases like Parkinson's and Alzheimer's disease. And what I'm very excited about is the whole notion of biomarkers that may enable us to make the diagnosis of Parkinson's disease at a time when it's not disabling. In fact, at a time when there may be no symptoms at all, and then intervene at a time when we can make much more of a difference. David, you mentioned the Fox Foundation and how supportive they've been of the American Brain Foundation. The Fox Foundation has a major initiative now called PPMI. This is an effort to assemble the largest cohort ever of individuals who we consider at risk for developing Parkinson's disease, who don't yet have it. And if we can begin to make a diagnosis and understand what happens in those sort of preclinical periods, then we can treat it much more effectively and actually begin to think about disease prevention, or at least slowing the onset.
It's really exciting. And I think the way a lot of neurology is going, the detection of prodromal disease before symptoms begin to enable us to intervene earlier. So Matt, how do people know they're at risk? What are the things, like in this PPMI study you're talking about? How are they identifying people who are at risk?
Well, let me give you a couple of examples. We did a large study called the PARS study, where we at Penn 30 years ago recognized that patients with Parkinson's disease often lost their sense of smell, or a big portion of their ability to identify odors. And many of them didn't even know it. And when we began to study it, we realized that there was no difference between patients with very early disease and those with advanced disease, that this seemed to be occurring before patients actually developed neurologic symptoms. And so in this one study we did, we took a cohort of individuals that were hyposmic, which means they couldn't identify odors. And we did a dopamine scan on a cohort to find which ones had low levels of dopamine, even though none of them had symptoms. And it turns out that 2/3 of those individuals that couldn't smell and had this low dopamine scan developed Parkinson's disease within 5 years. And then there's people have heard about REM sleep behavior disorder. These are individuals who have dream enactment behavior. That can precede Parkinson's disease and Lewy body disorders by 10, 15, 20 years. So there are signals out there, and that's not even considering our advances in genetics, because now we have at least 20 disease-causing genes that have been identified. And this brings up a whole nother interesting area, and that's the idea of how are genetics helping us? Well, the two common genetic causes of Parkinson's disease are something called LRRK2 and another one called GBA. And it turns out that LRRK2, which is a dominant disorder and not uncommon, particularly among certain subpopulations, causes an increase in an activity of a kinase, which is an enzyme. And we can come up with a treatment that reduces that effect. And so it's really important to identify individuals who have this enzyme defect or this genetic defect, because we may be able to treat them. And if it works in them, it may in fact work in patients who have non-genetic forms of Parkinson's. So the genetics are teaching us a lot about what may be happening in the brains of patients with Parkinson's disease. We think this is so important that under the leadership of Tom Tropea and Alice Chen-Plotkin at Penn, we are now genotyping as many of our clinic patients as possible. We have up to 1,000 now. We're going to try to genotype the entire population, because we'd like to assemble a cohort of several hundred of these individuals who have these mutations that we can begin to treat with some of these therapies. So that's a really exciting area that we're very enthusiastic about.
How common, Matt, are these mutations in it? If you take 100 patients with Parkinson's disease or 1,000 patients, what proportion are going to have identifiable mutations?
Probably around 5%. We're in our experience right now, and we're talking about just this one mutation or one or two mutations. It's a small number, but it may have a huge impact on what it teaches us. So of the 1,000 patients we've done so far, I heard this today, there are upwards of 50 or 100 patients that have been identified, which is almost in one center. And that's almost enough to do a meaningful clinical trial. So these therapies I think have a lot of potential, and we're very excited about them.
How about surgical intervention, Matt? What role does surgery play in the treatment of Parkinson's disease?
Well, I did want to say, again, because I think many of your audience are patients, that, a lot of times we spend time in these sorts of presentations talking about the future. And everything I've talked about so far is, 5-6 years into the future. But the other interesting thing that I think is almost more relevant is, what can we do for patients today? And I think that's obviously important. And my big thing is, everybody has a different sense of well-being. It's different for, everybody is defined differently. And in the clinic, we have to sort of understand for each individual patient what it is that makes them tick. And for those that have more advanced symptoms with what we call motor fluctuations, that have on time and off time, and you've really run out of gas with oral therapies, there is, you mentioned surgery, there's something called deep brain stimulation, and that can be very effective in reducing the severity of those off downturns. But it also brings up what's in the future. We are enthusiastic about many of the newer advanced, sort of more invasive therapies. We've only gotten so far with regular medications, but now there are new formulations of dopamine and dopa. There are infusion therapies that are being developed. So even deep brain stimulation, as effective as it is, we may have other options. In fact, we do have other options to consider before we go that route. So I think that this is a time of where we've really made great strides in reducing the impairment that patients are experiencing, even if they've had Parkinson's for many years. That's sort of the drug therapy side of things. The other side that people don't talk about very much is, what about the non-drug approaches that are so important in neurological diseases like Parkinson's? And, it sounds trite to talk about exercise and diet, except that it really does have an impact. And there are some studies that have shown that a regular sort of aggressive exercise program, that things like the Mediterranean diet may actually reduce the incidence and severity of Parkinson's disease. So I'm pretty aggressive about having patients, particularly, at any stage of Parkinson's, get involved in an exercise program and at least discuss dietary issues with them. I'm I'm not sure I'm going to change anybody's diet, in a big way, but there are some interesting studies that are now suggesting that we consider, a high consumption of olive oil and vegetables and cereals, fruits and vegetables and things like that, that sort of consist of the Mediterranean diet.
Yeah, yeah. You say that the overwhelming majority of patients with Parkinson's disease now live long and productive lives because of the medicines that we do have. Maybe just walk us through how these drugs work. You talked about dopamine and dopamine scans, but fundamentally, Parkinson's disease is a problem with dopamine. So many of the therapies that are used either kind of replace dopamine or pretend like dopamine's in the brain. Can you walk this group through that?
Yeah, so at least many of the motor symptoms, the ones that we commonly recognize, like tremor and slowness of movement and muscle rigidity, are really due to a deficiency in the neurotransmitter dopamine. And so dopamine replacement therapy with L-Dopa, which evolved in the late 60s and early 70s, was really a dramatic breakthrough in the treatment of any neurodegenerative disease. And the search has been on since then for drugs that mimic the effect of DOPA, but don't have some of the same side effects. In other words, patients that have been on L-Dopa for many years often have motor complications, lots of sort of on and off fluctuations and involuntary movements. And we've gone through a whole evolution of medications to try and improve our treatment of symptoms without those side effects. And it's funny how the pendulum keeps swinging in our business. It's maybe a little bit like migraine, I don't know, but we're kind of back to looking at the best formulations of L-Dopa now, because it's still the best drug, and others that we thought were effective have turned out to not be as effective or to have more side effects. And so I'm really enthusiastic about the newer formulations of L-Dopa that more closely mimic what happens in the normal physiologic situation. And those are infusions and long-acting oral formulations. These are all going to have a major impact on the modern day pharmacotherapy of Parkinson's.
Matt, when I was growing up, I would see a patient, or a neurologist would see a patient, and the question would be, does this patient have Parkinson's disease? And it for a long time was a clinical diagnosis based on the clinical features that the patient has. And because there are a lot of syndromes that look like Parkinson's disease. So where is the field diagnostically now in terms of your ability as a clinician to see a patient and accurately diagnose that patient and truly know that they have Parkinson's disease?
Yeah, that's a great question, David. And one of your colleagues, Chuck Adler, who was our first fellow, has done a lot of work on diagnostic accuracy. The bottom line is that we still make the diagnosis in the clinic, that it's supported by things like this dopamine scan I mentioned, but we don't do that routinely unless there's a diagnostic question. And when I look back at my own sort of career and wonder how many times I got it right and how many times I got it wrong, I think I probably got it wrong a lot, but not because of a recognizable disease, but because of the genetic variability. That there were probably a lot of syndromes that we didn't quite recognize that included what looked exactly like Parkinson's disease and responded to therapy like Parkinson's disease. And what that brings up for me is that many of our clinical trials over the past 25 years of drugs that were trying to modify the course of disease failed because in that group of patients, we were lumping all kinds of patients that looked like they had Parkinson's disease that probably had different subtypes and different pathologies with the same end result. And I'll give you one example. We've gotten very interested in the gut, as you may know, for a lot of diseases, but particularly Parkinson's disease. And there's something called the gut microbiome. This is the constellation of bacteria and fungi and viruses that inhabit all of our GI tracts. And it turns out that, in Parkinson's disease, preliminary studies have suggested that the population of those organisms may be slightly different. And that may have several different impacts, including on things like inflammation and the barrier between the gut and the blood, and may have a role in the pathology, the etiology of Parkinson's disease, because there's a direct connection between the gut and the brain through something called the vagus nerve. And it looks like the pathology in Parkinson's disease may start at the entrance of that vagus nerve into the brain.
Hmm.
So that's sort of caused this hypothetical question of, does Parkinson's disease actually begin outside the brain? And my guess is that in some patients, the answer is yes. And in some patients, it's no, that there are actually, this is the whole thing. There are probably different forms of Parkinson's disease, some that begin in the gut, some that begin in the brain, but they all end up in the same place pathologically. But
Yeah.
you can imagine that if and this is really, this may get beyond the confines of what we want to talk about, but this is really interesting because that vagus nerve that we talked about as the route to get to the brain from the gut, severing that nerve was a treatment, very common treatment for ulcer disease. And there have been a few studies that have looked at patients that have had that nerve severed, and lo and behold, their incidence of Parkinson's disease is less
Wow.
than in those that have not had that severed. That's one study. Is that true? Is that an epiphenomenon? I don't know, but it's certainly kind of intriguing, particularly since patients with Parkinson's disease often have constipation many years before they have the real disease. And the pathologic footprint of Parkinson's disease is a protein called alpha-synuclein, and we find alpha-synuclein deposits throughout the GI tract and the skin. So this disease, which we used to think of as purely a brain disease, may actually have a lot of extra cerebral manifestations, which makes it even more intriguing.
Fascinating. I want to ask more questions, but I'm sensitive to all of your questions as well. So please, I'm going to open it up shortly here, but if you want to type your question into the chat box, please don't hesitate. But while you're doing that, I'll ask you another question, Matt, and that is that you talked about all of the different non-motor manifestations of Parkinson's disease, one of which is unfortunately cognitive impairment. So how often does that happen? And what's the underlying basis for that?
Well, the underlying basis is the spread of pathology to areas of the brain that affect cognition. And we didn't see a lot of dementia when I first started out because patients just didn't seem to be living as long as now. We've sort of done a great job controlling the motor symptoms, and patients, as I said, are living long enough for us to see the spread of pathology into brain regions that cause more cognitive impairment. And it may be the biggest unmet need right now is therapies that prevent that from occurring. That's one issue. The other issue is, there's a spectrum between Alzheimer's disease and Parkinson's dementia, and often the pathologies coexist. So in many instances, we find the changes of Alzheimer's disease in Parkinsonian brains, and we find Lewy bodies and alpha-synuclein deposits in patients that look like they have Alzheimer's disease clinically. Mm-hmm. So there's an overlap of this, and it's very hard to distinguish these individuals during life.
Yeah. Okay, we're getting some questions rolling in here, so I'll ask you the first question, Matt, and that is, are mushrooms ever used medicinally to manage Parkinson's disease?
There are no clinical trials that I am aware of. Obviously, psilocybin and other medicinal related compounds from mushrooms have a great deal of medical interest now, and particularly in things like post-traumatic stress disorder and depression. But I'm not seeing evidence of efficacy in Parkinson's disease. The answer to that is I don't know.
Yeah. There's a question here about diagnosing Lewy body dementia after someone's been misdiagnosed with Alzheimer's disease. And the question is really, can alpha-synuclein be measured using any type of blood test or brain scan?
Yeah, I think that's a really great question. And it was one of the things I was going to mention, that this is a new area of research, the ability to pick up, very, very small amounts of alpha-synuclein in the blood or spinal fluid. We're not there. This is not ready for clinical use just yet, but it may be soon, the ability to sort of detect alpha-synuclein in patients that have Lewy body diseases. Lewy body dementia classically has a slightly different clinical presentation from Alzheimer's disease, um, and and so clinically we sometimes make that diagnosis, but we're wrong a lot. And there are a lot of patients who are diagnosed with Alzheimer's disease that on autopsy have Lewy body dementia and vice versa. So it's still an area of difficulty. What we don't have that is really going to have an impact is a radio tracer. So right now we can look at an Alzheimer's patient and look at amyloid, do amyloid imaging and pick up the pathology because it's an extracellular clumping of protein. In Parkinson's disease, the alpha-synuclein is intracellular, and it's a lot more challenging to get a radio tracer that will bind to it. But there are a lot of folks working on it, and once we have that, that will have a significant impact on our ability to diagnose Lewy body diseases during life.
Yeah. Excellent. Thank you, Matt. There's a question here. How do you define Parkinsonism?
The same way I defined it at the beginning of this presentation. Parkinsonism are patients who have Parkinson symptoms, tremor, rigidity, muscle slowness, and look like they have Parkinson's disease. Parkinsonism can be caused by drugs, particularly antipsychotics, can be caused by other neurodegenerative diseases that resemble Parkinson's disease. So Parkinsonism is an adjective that defines someone who looks like they have Parkinson's disease.
Yeah, excellent. Is Parkinson's disease a unique diagnosis, or are there other neurological problems also present? You kind of touched on that with the potential for dementia, cognitive impairment, REM sleep behavior disorder. Anything else you want to say to that?
Simply that there are a lot of what we refer to as non-motor symptoms of Parkinson's disease that in many respects are more of a source of disability than the motor symptoms that you all are familiar with. For example, depression, anxiety, very, very common in Parkinson's disease. And the thing is, I just want to say to the patients out there, again, know your sense, know what it is that defines your sense of well-being, and bring it up with your doctor. If the doctor's not going to ask you. So you need to understand what it is about your situation that affects you most and bring it up with your doctor. There are just too many of these non-motor issues that a doctor won't mention. I once gave a talk at the Movement Disorder Society. They wanted me to talk on non-motor symptoms. So I took a video camera into my exam room the next week to get ready for this talk. And the first patient that came in, I said, "Do you mind if I videotape our discussion?" No problem. I said, "How are you doing?" The famous question that every doctor asks their patient with 20 other patients sitting in the waiting room. Patient said, "I'm fine." I said, "Are you fine?" He said, "I'm fine." I said, "Terrific. Do you have any Parkinsonian symptoms?" He said, "Occasionally I have a little bit of a tremor." I said, "Okay, we can sort of adjust your medications. And if we get rid of that tremor, is that you gonna be happy?" He said, "Doc, I'll be thrilled. That's fine." I said, "Do you mind if I ask you a few more questions?" He said, "No, go ahead." I said, "How do you sleep?" He said, "Terribly. I'm up all night long." I said, what do you do when you're up at night?" He said, "Oh, I get on my computer. I got to go to the bathroom 4 times a night." I said, "What do you do when you're on your computer?" He said, "Usually I gamble."
Oh.
Every question I asked him, he answered, "Yeah." So the point of that is to say that the doctor's not going to ask. You got to bring it up, because all these things are treatable. Depression's treatable, anxiety is treatable, sleep problems are treatable, bowel and bladder problems are treatable, and yet they can be a source of great disability. And doctors are biased. And patients don't want to go into a doctor and say something that's going to make the doctor say you're getting worse. And you're not getting worse. You just have symptoms that a lot of us have. I get up at night a couple of times. So don't be afraid to discuss these things with your doctor.
Now, a lot of people just accept them as just the way it is. And
Yeah.
there's nothing that we can do about it, and they don't want to complain about it. And I asked a patient this afternoon, "Are you satisfied with where you are right now, given the particular disease I was treating?" And she and her husband sat there and said, "Yeah, no, I'm satisfied." And her husband, I said, "Are you satisfied?" to her husband. And he said, "Not really." And so I said, "Well, why is that?" And so then it opened up a whole new a can of worms, but you're absolutely right. If you probe, it's amazing what you'll find.
Right. And and doctors just don't probe enough because they don't have time. And you know, a lot of doctors are just not oriented that way.
Yeah.
And I think it's really, I'll say it again, it's really important for individual patients to understand what it is that defines their own sense of well-being. And that's going to be different for every patient.
Yeah. There's a question here, Matt. What do you think of xenotide?
I don't know. I think the jury's still out. I don't want to comment too much because I haven't really looked at the data carefully, but I think the jury's still out on that one.
There's a question here talking about the vagus nerve. I was diagnosed with Parkinson's disease 2 years ago. I have hiccups several times per day and always questioned whether this was related.
I don't think the hiccups, even though they're related, the hiccups are usually related to a nerve called the phrenic nerve, which is the nerve that goes to the lungs, and not the vagus nerve. So I would say probably not.
Okay. What are some areas of your work overall that have you the most excited as far as certain treatments of Parkinson's disease moving forward?
Well, as I mentioned earlier, I think I'm most excited about the notion of prodromal disease. That is, what I mean by that is diagnosing and detecting Parkinson's disease before it becomes symptomatic, because I think that's the key to really having a major impact on this disease, like it is on other neurodegenerative diseases as well. And as I said earlier, we really have lagged behind medicine in general in the whole notion of early detection and prevention. And I think that's where the next decade of work will go in this area. And that's what I've spent my time, the last years of my research career has been involved in early detection.
Yeah.
And I think that's where the field is heading.
Yeah. This is you may not be comfortable answering this, although you may be. What are the top treatment centers in the United States? Penn, Mayo, Stanford? This patient's obviously looking for perhaps a place to go.
Yeah, that's a loaded question. There are a lot of great centers, and fortunately, you can almost be anywhere in the country and get treated well. I think certainly yours at the Mayo Clinic and Penn, they're all good. The problem is it's having a doctor that you can relate to is a very personal experience. And a lot of my colleagues that I have such respect for their work and what they've contributed to the field, sometimes I've seen patients that they've seen, and I've not been terribly impressed by what the patient tells me they've been told by that particular individual. So don't be afraid to shop around. I mean, the best doctors are not necessarily the ones that sort of Harvard and Stanford. They may be out in the community, and get a second opinion. Read, talk to other patients, bring questions in to your doctor. That's the most important thing.
Yeah. Yeah.
And if you're not satisfied with the answer, go to see someone else.
Well said, Matt. Because you're not going to see an institution, you're going to see an individual
That's
at
right.
that institution.
That's right.
Yeah. Here's a question, or perhaps an opinion. As I've learned more about Parkinson's disease, I'm now thinking about it in terms of not a disease, but a syndrome, since it has so many different manifestations and is so different in so many people. What do you think about Parkinson's syndrome?
I think it's a really good point. I think as we learn more and more about the variable etiologies, we almost have to look at it as a syndrome, because it doesn't have just one cause. And for a disease that may have several different causes and several different pathways to get there, I think it's totally rational to think of it as a syndrome.
Yeah. Here's an interesting question, Matt. Is there any link between traumatic brain injury and Parkinson's disease? Is TBI a risk factor for PD?
It may be. It may be one of many risk factors. The research on that one has been controversial. We once did a study years ago on traumatic brain injury and Parkinson's disease. And the problem is when you ask patients with Parkinson's disease whether they've had head trauma, patients with any neurological condition are more likely to remember an episode of head trauma than someone who hasn't had any kind of neurological disease. So there's some recall bias in these studies. And I hate to even get into the animal study question because it's such an awful thing to think about. But in the early days of animal research, there was no evidence that head trauma caused a pathology that looked like Parkinson's disease.
Yeah.
So patients who have pugilistic Parkinsonism, or the sort of Parkinsonian symptoms that occur after years and years of head trauma from boxing, have Parkinsonism. They're slow, they're stiff, they move just like a patient with Parkinson's disease, have a different pathology.
Yeah. We're your former mentee and student and I are involved in a big NIH supported project looking at the influence of repetitive head impacts in football players. And so one of the things obviously we're looking at very carefully is those patients with features of Parkinsonism and Parkinson's disease. So there, as you say, there's a lot of people looking at this area, but I think the jury is still out.
Well, it may be very hard to distinguish. I mean, certainly patients with chronic traumatic encephalopathy, you know, the thing that we see in ex-football players,
Yeah.
or current football players, those patients can look for all the world like they have Parkinson's, but their pathology, what the brain looks like, is quite different.
Yeah. There's a question here, Matt. My husband has dementia and Parkinsonism. And her question is, how can we distinguish between Lewy body dementia versus dementia with Parkinsonism? And I think the main question here is, would the medications be different? So could some of the medications for LBD hurt someone who has Parkinson's disease with dementia?
You know, I think that the treatment is very similar for all of these dementias. And the most important thing is to avoid medications that make the cognitive symptoms worse. So in patients who have Lewy body dementia and who also have significant Parkinson's, often it's a very difficult balance between treating the Parkinson's and making the dementia worse.
Mm-hmm.
So that is the only caution that we urge that we have with patients who have classic Lewy body dementia with Parkinson's. Patients who have Parkinson's disease and then develop dementia look like, and this is an arbitrary distinction, because we say that if someone with Parkinsonism who develops dementia or cognitive impairment within 1 year of their motor symptoms, that's Lewy body dementia. If it's greater than 1 year, it's Parkinson's disease dementia. Well, you can imagine the overlap there has to be with some kind of arbitrary distinction like that. So there's probably a spectrum. And the bottom line is, you know, if someone has dementia with Parkinsonism, you have to be careful with treating the Parkinsonism, because it can make, with dopaminergic medications, because it can obviously make the dementia a little bit worse.
Yeah. I guess on the opposite side, treating someone with Lewy body dementia who has hallucinations, delusions with antipsychotics, for example, can make their Parkinsonism worse.
Exactly. Unfortunately, we have better antipsychotics now, which has been another significant advance in the sort of armamentarium for treating these conditions, that have less Parkinson-related side effects. So these are called atypical neuroleptics for one. There's some others. There's one called Nuplazid that is just for patients with, you know, Parkinson's-related psychosis. So there are medications that are effective that have a lower risk of side effects.
Yeah.
The bottom line is, you know, there's always something to try. And even though patients who have Lewy body dementias and other forms of dementias can be very, very challenging to treat and very challenging to care for, there's usually always something to try to improve their function. And the only thing I would add to that is that, you know, I see that there, from the questions, that there are some caregivers out there that are dealing with some challenging loved ones, and just understand that the caregiver burden is a major issue in this whole spectrum, and it's important for caregivers as well to make sure that they are being adequately treated. I just think it's important to throw that in.
Yeah, absolutely. Question here: what recommendations do you have if there are if a patient is interested in participating in a clinical trial for a new drug or a new formulation of an existing drug?
Well, number one, the most important thing is talk to your neurologist about that. And your neurologist should be plugged in. And if they're not, there are a number of websites to check. The Fox Foundation is a great website that will tell you what clinical trials are recruiting. Clinicaltrials.gov is another website that tells you what clinical trials are out there in Parkinson's. But the first resource should be your neurologist.
Yeah. You mentioned exercise, Matt, and the question here is, are there any specific types of exercise that are particularly effective for reducing Parkinson's disease symptoms, especially tremor?
Yeah, I think that's a great question. And I think some of my colleagues would answer with specific exercises. I'm not, people say boxing is terrific and riding a bike is great for Parkinson's. And I think that's all true, but I'm more interested in getting someone just exercising, period. And it can be pretty moderate. It doesn't have to be significant. And I usually tell patients, look, if you like to walk and you can walk a couple of miles 3 or 4 times a week, that may be adequate. That may be terrific. If you can do more than that and you enjoy it, go for it. But the point is not to torture yourself, but to be active. And that's been my philosophy with exercise. And as time goes on, we may show that there are specific exercises that are more impactful. But in my experience, the patients that I have that are doing the best are the ones that exercise regularly in any form of exercise. It can be playing golf, it can be playing tennis. Just exercise regularly has a huge impact on patients' sense of well-being.
Not playing golf here in the desert, Matt. We're on a cart.
Yeah, right. Well, you have to walk. You have to get out of the cart.
Yeah, exactly. There was a couple of questions here about the effectiveness of the DAT scan. You referred to the dopamine scan earlier. So how effective is that for the early diagnosis of LBD, Lewy body dementia?
Well, I think the DAT scan is an effective tool for showing that there's an abnormality in dopamine neurotransmission. It's actually, you're measuring the dopamine a dopamine transmitter. And we used it as a screening tool in our PARS study because it is so sensitive to picking up early abnormalities in dopamine function in the brain. We don't usually use it routinely for diagnosis, but I think it's having an impact on early detection. And it may become a more relevant tool for early detection to be used in combination with other factors like genotyping, smell testing, things like that.
Yeah.
Right now, for example, if we have a patient who has a tremor, and we're not 100% sure whether that tremor is a familial tremor or a Parkinsonian tremor, sometimes we'll go ahead and use a DAT scan to differentiate. It'll be normal in essential tremor and abnormal, obviously, in Parkinson's. So it can be very effective at differential diagnosis.
How about the DAT scan as a measure of prodromal disease onset, even before symptoms?
Yeah, well, that's where I think it may have a more expanded role. So as I said, in the study that we just published last year, we used the DAT scan and smell testing as our screening tool, and found that if a patient did have an abnormality in their DAT scan, the 2/3 of those individuals, even though they had no symptoms at all, the 2/3 of those individuals were going to go on and develop Parkinson's disease. So it may turn out to be a very effective early screening tool.
So you really are, the field has developed a library of opportunities or options to diagnose this disease very early on, even before symptoms. It's really encouraging.
Well, I think that's where this field is going. As I said, the Fox Foundation has invested a tremendous amount of resources in studies to put these cohorts of at-risk patients together, so that we will learn a lot about their genetics, about their clinical symptoms, their premorbid symptoms. All of it's going to become part of the science of Parkinson's disease, and it's not far off in the future. This is stuff that's happening within the next couple of years.
Exciting. Someone asked, my grandfather had Parkinson's disease and passed away from it. And I'll ask the question and then broaden it a bit. Could his taking a time-release B vitamin supplement have potentially helped slow the progression of the disease, since they can help with nerve damage and deterioration? And I guess the broader question is, where's the field now with regard to supplementation in people with either at risk or with Parkinson's disease?
Yeah, again, I don't want to put a damper on anybody's desire to take ancillary medications. There's no data that suggests that this kind of supplementation will slow the progression. There's no data that suggests that it won't either. They just haven't been studied that effectively to know for sure whether they have any kind of role. But there's been no good data to suggest that we should recommend vitamin B or D supplementation for patients with Parkinson's disease.
Here's an interesting question. Is Europe or any other global locations approaching PD any differently than we are in the United States?
Yeah, that's a great question. And the answer is our world has gotten really, really flat, to quote Tom Friedman. We are in such good communication with our colleagues around the world that there is really great work being done everywhere. And we all get together so frequently in our fields, as David will attest, that we really speak the same language around the world when it comes to that. Now, there are some drugs and treatments that are available in some places that aren't available in others.
Yeah.
But in terms of basic research into the causes and ultimate treatments, we're pretty much on the same page.
Yeah. There's a question from a ringer in the audience. Is the new SynTap biomarker test announced this month by Amprion that detects alpha-synuclein in CSF a breakthrough in terms of being able to detect alpha-synuclein in Lewy body patients?
Well, I also started to allude to this, the ability to detect tiny amounts of alpha-synuclein through seeding technologies. I don't know. We'll see. Maybe that person can make themselves available, make a comment about it. We've been looking at synuclein levels in the spinal fluid for a while, and the data's been really sort of up and down. Some studies find a little, some studies find a lot, but this is the ability to detect minuscule amounts. It's kind of like the way we are looking at prion diseases. That's, I guess we won't want to get into that here. But I think the ability to detect minuscule amounts of misfolded synuclein will become very important in this whole early detection paradigm.
Mm-hmm. Are we getting close to finding a disease-modifying medication?
Well, we talked about this a little bit earlier. We've been looking at we've been looking for disease-modifying therapies for, as I said, for 30 years. And we have largely failed, at least clinical trials have largely failed. I'm not sure that's because of the medication not being effective or because we didn't have the clinical trials methodology to fully study a disease-modifying therapy in this disease. Now, that's why we're so interested in subtyping Parkinson's disease and looking at genetics and getting a better idea of, can we purify a population? And if we can do that, I suspect we'll be able to impact disease progression with some of the therapies that we've already perhaps tried. We have antioxidants. We've looked at other disease-modifying approaches. We've looked at growth factors and neurotrophic factors. I suspect that if these are used earlier in a specific subpopulation of patients, they might be effective.
Yeah. Because another question that came in is, if you're able to diagnose earlier, would your initial treatment pathway still be the same or different, to your point?
Yeah. I don't know. I mean, I think that's sort of the question of the hour. I think if and we'll start to get more and more of these questions. I have a family history of Parkinson's disease. I have REM sleep behavior disorder. I've noticed that I can't identify odors. Do I have Parkinson's disease? And if so, what should I take? And again, without getting into the specifics, if I had that, I wouldn't sit here and say, I'm not doing anything until I have neurologic symptoms. I would say, I'm going to start an exercise program. I'm going to change my diet because there's some evidence. And I'm probably going to take an MAOB inhibitor and maybe some other things that I think might be impactful.
Yeah.
And you could say, well, there's no data to support that. Well, that's right. There's not sufficient data, but there's rationale.
Yes.
And sometimes we have to treat based on rationale and not necessarily data.
How about gender, Matt? Men versus women in terms of the progression of Parkinson's disease.
There's some data on that, but there's a slightly higher incidence of Parkinson's disease in men than women. Why is that? We're not 100% sure. Men may progress a little bit, get to a worse point faster. I don't know. I don't think there's sufficient data to really understand that difference. There's some folks that have looked at estrogen and sort of female hormones and said that they have an impact on disease progression. Maybe.
Yeah. There's a question here on a topic we haven't touched on yet, and it comes from somebody who asks, my brother, who's 69, suffers from Parkinson's disease since 2010. And presently he's described mitogen for low blood pressure and falls constantly. And from what I observed, before he falls, he becomes like a statue. And so this brings up the whole issue. I think dysautonomia is another non-motor manifestation of Parkinson's disease. And obviously this person's struggling with this. Any comments on that, Matt?
Yeah, to me, if the dysautonomia is so severe, that brings into question the diagnosis again. I mean, patients with Parkinson's disease, particularly treated Parkinson's disease, almost always will have some degree of lowering of blood pressure. But when it gets to the point where they're actually falling from low blood pressure, I wonder whether they may be sort of blurring into what we call a multi-system atrophy or a Parkinson's with autonomic failure. Those patients are extremely challenging to treat. They're usually impaired not by their Parkinson's. They're usually impaired by their falling and low blood pressure and other symptoms of multi-system atrophy. This is the patient who becomes like a statue, cannot move, and then falls.
Yeah.
It's a really challenging problem.
The bottom part of that question is asking about fecal transplant and stem cells. Looks like the question is, in Houston, Texas, is there an FDA approved either study or treatment where there's something's extracted from stem cells and bone marrow and injected back into PD patients?
No, I don't know anything about that, and I'm also really, really wary or leery of some of these kind of stem cell factories that have caused medical tourism. There is no data that injecting patient's own bone marrow or whatever creates a significant improvement, at least not enough to warrant widespread use.
Is there a relationship between the use of Paxil and REM sleep behavior disorder and later Parkinson's disease?
There's a relationship between REM sleep behavior disorder. I'm not aware of any relationship between the use of Paxil and the risk of developing Parkinson's disease. But REM sleep behavior disorder is a fascinating syndrome in itself that may have its roots in the brainstem in the same region where Parkinson's may begin. And so it's no surprise that this may be a significant warning sign for patients that may develop more typical Lewy body disorders 10, 15 years after first developing this sleep disorder. So this is a fascinating area of study as well.
I don't know if somebody's trying to ask a question live or...
Someone is bound to ask about CBD and THC, right? I think David froze.
Why don't you answer your question on CBD?
No, I mean, so this is my final comment about these sort of atypical therapies is that if it helps you, go for it. Just because this has not been something that's been studied or has been proven effective, if it works for you and it's not harming you, then I'm all for it. Jane, you better come back. Can you see David? You're on mute.
You're on mute, Jane.
Jane, can you hear me? Because you're on mute.
Sorry, I thought I turned my mute off.
No, there you are.
Okay.
David disappeared.
There was somebody who asked a question about vitamin D. Does that have any impact?
Yeah, we mentioned that. It may, it's not, the data has not supported it, but again, I put that in the category of CBD. If it's something that, certainly if you have vitamin D at low levels, it's worth taking, but I don't think there's been good data on it improving Parkinson's. Wearable devices to reduce tremor. We've seen some efficacy from some of the wearable devices. We've addressed CBD. Someone asked about red wine. I'm probably going to have some in about 5 minutes. Again, if it helps you, there's evidence that a little bit of red wine every day is good for you.
What about meditation? Somebody asked about that.
Again, I put this in the category of non-pharmacologic treatments that have not been studied in large populations of patients, but meditation is good for you. They're good. It's good for you, Jane, and for me. So why shouldn't it be good for someone with Parkinson's? So meditation, Tai Chi, Qigong, things like that can be very helpful for some people. Try it. If you're a patient and you're motivated, try it and see if it helps you.
Okay. Do you see anything? We're almost at time. Do you see a question in the chat that's of particular interest to you, Dr. Stern?
I just want to be clear. Someone asked about, are you saying that RBD is connected with Lewy body dementia more than just Parkinson's? No, I'm saying that RBD is connected with all Lewy body disorders, both Parkinson's and Lewy body dementia. So I just want to be clear on that. Don't see anything else. Can a person with PD develop scoliosis?
Well, I got word from David Dodick that his computer completely shut down and he can't start it. So the computer gremlins are out tonight. And I think that we should wind up now. I want to thank you so much, Dr. Stern. I know that a lot of people on this call are, just from their questions, they're directly affected or their loved ones are. And this was a really helpful opportunity to hear about the latest research and to hear, what the treatments might be effective, et cetera. So thank you so much from the American Brain Foundation. Emily, are you going to put up a few last slides there? Just want to let everybody know that we have monthly events like this. The next one coming up is on multiple sclerosis, what is giving us hope. And so we'll learn from a prominent neurologist at the University of Chicago that night. And then we're going to have on December 16th, an event called Acute Stroke Treatment and Mobile Stroke Units. So this is where down in Houston, they've developed almost like a Batmobile for stroke to get to stroke patients really quickly. So I hope you'll tune in for those. Next slide. Join us. Receive news and updates through any of these social media handles. We'd love to have you follow us and interact with us. And next, and this is how you can donate to the American Brain Foundation. We, of course, appreciate your donations, and your funds that you give go toward our research mission, including the support of research in Parkinson's disease. So you can make a donation to the American Brain Foundation, at this link, and I think somebody just put it in the chat. Thank you so much again, Dr. Stern, and thanks everybody for coming tonight.
Thanks, Jane. And
See you next
Emily.
time.
See you next time.
Okay.
Bye-bye.